Hello, everyone. My name is Becky.
And I'm Lauren.
And my name is Amivi.
And today we are going to be presenting our Pediatric Interventions project on brachial plexus injuries. We would like to begin the presentation with reading you a case study so you have an understanding of what our intervention will be based off of. So, Nicole is an 8-year-old girl whose family lives in the suburbs of New Jersey. She lives at home with her mother, father, and older brother. She is currently in 3rd grade and attends public school. When not in school, she enjoys being outside and staying active by playing sports with her brother, including baseball, football, and basketball. She was recently involved in a traumatic accident at the local park while on a family outing. Nicole was attempting to toss the ball to her brother when she was bit on the axillary region of her right upper extremity by a dog. An ambulance was called and she was taken to the emergency department for further evaluation. Medical testing revealed that Nicole had suffered a brachial plexus avulsion injury. When the dog bit her, he latched onto her arm and shook her a few times, ultimately severing the nerve roots from the spinal cord. Nicole underwent several surgeries where doctors attempted to reattach the nerve root by completing reimplantation techniques. She required extensive occupational therapy in the acute and inpatient rehab settings. She was ultimately discharged from inpatient rehab and followed up with an outpatient occupational therapist for splint management. It's now been 2 years since her initial reimplantation surgery, and she has regained some motor function, but still has weakness along with sensory deficits. She is seeking outpatient OT services to help improve her strength, range of motion, coordination, sensory deficits, and functional independence. To give you a little background of the brachial plexus, it is a bundle of nerves that innervates the upper extremity. The image below here displays a good representation of the roots, trunks, divisions, cords, and branches of the brachial plexus. Brachial plexus is made up of 5 nerves, and as you can see here on the screen, each nerve has a certain specific innervation throughout the upper extremity. It is important to note that injuries to nerves that root higher up on the spinal cord in the neck affect the shoulder, and if nerves that originate lower in the brachial plexus are injured, the arm, wrist, and hand are affected. The next 2 slides that you'll see here are the 5 different types of brachial plexus injuries. For this presentation, we are going to focus on brachial plexus avulsion injuries, which you'll see on the right side of the screen. This usually happens through trauma, and the root of the nerve is completely separated from the spinal cord. Amivi is going to describe to you a little bit more in specifics about a brachial plexus injury.
So a brachial plexus avulsion is an injury that occurs when the root of the nerve is completely separated from the spinal cord. Sometimes the nerves are only damaged or stretched. After a nerve repair surgery or injury, the nerves must regrow from the site of the injury, which occurs at a rate of 1 inch every month. Its causes are typically trauma, athletic injuries, gunshot wounds, medical trauma, cancer, and radiation therapy. So the most common brachial plexus injuries are the brachial plexus birth injuries, in which 1 to 2 out of 1,000 newborns are affected daily. And typically brachial plexus injuries affect ages from birth all the way to adulthood. And there are currently no statistical information on the brachial plexus avulsion, and little is known about its pathophysiology. However, more research is being conducted on it. So the symptoms are severe pain, weakness, limpness, or paralysis in the muscles of the affected arm or shoulder, lack of muscle control, lack of sensation or feeling, and the diagnostics are used to diagnose it are the EMG, MRI, MRN, and the EPS. So Nicole's occupations that are affected by the brachial plexus injury are ADLs, IADLs, leisure, play, and education. The deficits present that hinder her occupational performances are decreased right upper extremity strength, decreased right upper extremity range of motion, decreased sensation, poor bimanual coordination skills, and decreased right upper extremity endurance.
Okay, so now we're going to talk about Nicole's impacted performance skills. First is reaches. Nicole demonstrates inefficient and inconsistent extension of her right upper extremity. Grips. Nicole has difficulty flexing, adducting, and opposing her fingers and sensing the pressure to effectively grasp or pinch. Manipulates. Nicole lacks precise motor dexterity and proprioceptive perception when handling objects. Coordinates. Nicole struggles to efficiently manage bilateral and bimanual tasks. Moves. Nicole pushes or pulls without enough force. Lifts. Nicole inconsistently raises objects off of the surface. Calibrates. Nicole uses too little force or speed when interacting with objects. Flows. Nicole's right upper extremity movements are uneven during tasks or activities. Endures. Nicole displays physical fatigue when completing certain tasks or activities. Paces. Nicole performs with an inconsistent rate. Handles. Nicole offers limited necessary support for objects. And accommodates. Nicole sometimes cannot prevent unintended errors. So goal number 1 is in an outpatient setting. Nicole will complete self-feeding tasks with modified independence using a right gross grasp on built-up utensils in 6 weeks. Goal number 2 is also in an outpatient setting. Nicole will demonstrate improved bimanual coordination needed for ADLs, for example, zipping her coat, brushing her teeth, cutting her food, with modified independence using adaptive equipment in 6 weeks. And the specifics of our intervention activities, the performance skills that we're addressing are reaches, grips, manipulates, coordinates, moves, lifts, calibrates, flows, endures, paces, handles, and accommodates. And supplies that we've used for the interventions are a mat table, a mirror, an activity table, a basin for water, washable paint, a paintbrush, a washcloth, water, a therapy swing, a stretchy rope with 2 handles, 5 buckets, 4 bowling pins, TheraPutty, a rubber gripping tool, fork, a utensil foam grip, and a caterpillar used as a model.
The overview for our activities and for our intervention. So for the first 10 minutes, we'll be providing, or the client will be doing active assisted range of motion exercises in front of the mirror for visual feedback. The next 15 minutes will consist of sensory reintegration activity for the right upper extremity. The next 15 minutes will consist of weight-bearing activity to facilitate neuromuscular reintegration. And during the last 15 minutes of the intervention, we will focus on bimanual coordination activity to encourage right upper extremity involvement and improve hand strengthening. So a time component is allotted in each activity for the setup and cleaning for all items and surfaces used. An additional 5 minutes will be given at the end of each session in order to dedicate towards effective communication with the caregiver. And this allows for time for any education or questions before the individual session ends.
All right, so for activity 1, we're going to do active assisted range of motion exercises, ideally in front of a mirror, but as you can see, we didn't have a mirror here set up. But just to give a little description about this activity, while in a seated position, the patient will participate in a warm-up activity, including stretches and exercises of her right upper extremity. To begin, the therapist will perform passive range of motion stretches across all joints of the right upper extremity. It is important that the therapist reassesses the patient's range of motion each session. After the therapist performs passive range of motion, the patient will complete active assistive range of motion stretches of the shoulder, elbow, and wrist. Following the active range of motion stretches, the patient will complete scapular mobilization exercises. This will include scapular elevation, depression, protraction, and retraction. For clarity, the patient will complete one set of 10 repetitions for each motion listed. These motions will include shoulder flexion, extension, abduction, adduction, internal and external rotation, and horizontal AB and adduction, elbow flexion and extension, wrist flexion, extension, and radial and ulnar deviation. For activity 2, we will do a sensory reintegration activity for the right upper extremity. The therapist will set up the table with washable paint, a thick paintbrush, a basin of water, and washcloth. The patient will sit in a chair or stand at the table. To incorporate sensory reintegration and desensitization strategies, the patient will use her left hand to submerge the paintbrush in paint, followed by stroking the paintbrush directly onto the skin of her right upper extremity. The patient will complete the previously mentioned steps and with multiple colors of paint. Once all the paint has been applied, the patient will maintain a seated position at the table with a small fan position directly at the arm, allowing the paint to dry and harden. While she is sitting and letting the paint dry, the therapist can clean up all the items used. At the same time, the therapist can prepare a basin of water along with a washcloth. The therapist can then assess the patient's arm to make sure the paint has completely dried. We would like the paint to completely dry for the next step of the activity so that the removal process is thorough. Once the paint is identified as dry, has visible cracks on the skin, the patient can stand up and place her arm into the basin of water while holding the washcloth in her left hand. She can scrub the paint off her right arm. Once all the paint has been removed, she will use a towel to dry off and check her skin to make sure all the paint has been removed.
Okay. Activity 3 is a weight-bearing activity to facilitate self-feeding and dressing through neuromuscular reintegration, bilateral coordination, and manual dexterity. For this activity, Nicole chooses the swing she wants to use and helps the therapist support the swing with both hands as it is hung up by the therapist. The patient warms up by pulling herself in a seated position on the swing as she holds 2 handles of a stretchy rope. The therapist then gives Nicole choices for the movement activity and asks her to help set up. The patient turns lightweight buckets upside down, placing 4 in a row on the floor, and a 5th bucket is put right side up in a different area. The patient places 1 soft bowling pin with her right hand on each of the 4 buckets, ensuring to carefully balance them. The patient positions herself on the swing and prone with about 1/3 of her upper body off the front of the swing. She uses both arms to move herself towards the first pin, reaches and grasps the pin, and then uses both arms to turn herself and move toward a bucket behind her. Once close enough, Nicole drops the pin in the bucket and then moves herself on the swing with both arms back toward the remaining bowling pins. This sequence is repeated until all 4 pins are in the blue bucket. When the activity is complete, the patient helps the therapist to collect the pins and put them away in the closet, and she uses both upper extremities to stack the 5 buckets together.
So for activity 4, we will be using bimanual coordination in order to encourage right upper extremity involvement and improve hand strengthening for ADLs that require grip and dexterity. So the therapist and the patient will sit in chairs at the therapy table. The patient takes a rubber gripper in her right hand to help her open the third putty container that will be held in her left hand. The therapist and patient will then discuss what animal she wants to shape the third putty into. And then the patient will use a fork while stabilizing with her left hand to help her loosen the putty around the edges and then get it out of the container using her right hand. The patient would then use the fork in her right hand with moderate assistance to separate the putty into pieces. The therapist would then offer moderate assistance with guiding hand placement as the patient rolls and pinches the putty into its desired thinness. Then Nicole will then use both hands to move the rolled putty and the pinched pieces into shapes with minimal assistance until the caterpillar has been imitated to her satisfaction. And in this activity, the performance skills that are addressed are grips, manipulation, calibrates, handles, coordinates, and moves.